Anatomical Principles of Endoscopic Sinus Surgery, a step by step approach by Renuka Bradoo. Endoscopic Anatomy. Begin by being a surgeon on the dead body with as much care and precision as though it were a live patient. Endoscopic Anatomy. Endoscopic anatomy is best studied using a fresh cadaver specimen, which has not been formalized. This is because the feel of the tissues closely mimics that which is felt during live surgery. However, in the absence of a fresh specimen, a formalized cadaver will also reveal all the intricacies of anatomy to the avid learner. In learning endoscopic anatomy, we will try to follow the steps of surgery as closely as possible as in a live patient. Diagnostic endoscopy. A careful and methodical diagnostic endoscopy is the key to understanding anatomical variations, pathological processes, and to planning one's approach for surgery. It consists basically of three passes. First pass. The 0 degree scope or 30-degree scope is passed gently along the floor of the nasal cavity between the inferior turbinate and the septum without touching either structure. First pass showing the left nostril, inferior turbinate and middle turbinate. The septum is studied for any spurs and deviations. The inferior turbinate is examined for hypertrophy, especially at its posterior end. Any pathology obstructing the posterior choana is noted. The scope is advanced into the nasopharynx. The posterior wall and roof of the nasopharynx is examined to look for the presence of adenoids. The ipsilateral aestration tube and the cleft behind it, that is, the fossa of Rosenmuller, are examined. The contralateral aestration tube may also be seen, but it is seen better with a 30-degree scope, which is advanced into the nasopharynx and rotated. The depth of the fossa of Rosenmuller are best studied by 30-degree scope passed through the opposite nostril. On withdrawing the scope, the inferior turbinate and septum are reviewed and the scope is rolled into the inferior meatus under the free margin of the inferior turbinate. As the scope is being withdrawn through the inferior meatus, the floor of the inferior meatus is studied for the opening of the nasolacrimal duct. This is guarded by a fold of mucous membrane called the Haynes valve. This can be confirmed by the movement seen in this area on applying pressure near the lacrimal fossa. The scope is withdrawn out of the nostril. This is the diagram showing the first pass. And fossa of Rosenmuller is marked in a star. Second pass. The scope is passed along the floor up to the posterior choana. It is then moved upwards medial to the middle turbinate along the floor of the posterior choana and the anterior surface of the sphenoid. The superior turbinate and meatus are seen. The sphenoethmoid recess is visualized. It lies between the superior turbinate laterally and the septum medially. It is bounded above by the base of the skull and is continuous inferiorly with the posterior part of the nasal cavity. The sphenoid ostium opens into the sphenoethmoid recess 1 to 1.5 centimeters above the roof of the posterior choana and a few millimeters away from the septum. It is very often hidden from the view by the superior turbinate, which may need to be partially excised to visualize the ostium. The ostium shows variations in size and shape, being circular, oval, and sometimes only pinpoint in configuration. This diagram shows the second pass, the superior turbinate, the middle turbinate, and sphenoethmoidal recess. Below the ostium at the roof of the posterior choana is a mesh of blood vessels which form the Woodruff's plexus. The septal branch of the sphenopalatine artery runs along across the anterior wall of the sphenoid in this region. This pass should be practiced as gently as possible without touching any of the turbinates, as it can be quite painful in the live patient. We can see the superior turbinate and the septum and the choana. Third pass. The third pass is made to examine the contents of the middle meatus. The middle meatus can be entered by gently retracting the middle turbinate medially with the Freya's elevator. This may be difficult if the middle turbinate is rigid and may give rise to pain in the live patient. The second simpler method to enter the middle meatus is to advance the scope posteriorly and roll the scope under the inferior border of the middle turbinate to enter the more roomy posterior part of the meatus. The scope is then withdrawn from the posterior to anterior to view the contents of the middle meatus. Here we can see the third pass, agonized cell, rigid overlying nasolacrimal duct, given in a star. However, if one goes in an anterior to posterior direction, one first sees the most anterior one-third attachment of the middle turbinate to the cribriform plate. This arch-like attachment has also been called the axilla of middle turbinate. The olfactory fossa can be examined in this area. A bulge may be present in the region where the anterior end of the middle turbinate attaches to the lateral wall. This is found by an underlying well pneumatized agonized cell. With the meatus most anteriorly is curved boomerang shaped uncinate process. A groove may be seen where the uncinate process attaches to the lateral wall. This is the junction of the uncinate process to the lacrimal bone. The area anterior to the uncinate process overlies the lacrimal sac. This area extends downwards in the form of a diffuse ridge to reach a peak in the attachment of the inferior turbinate. This ridge overlies the lacrimal duct. The bulge of the bulla is seen behind the uncinate process. The groove between the two, that is the hiatus semilunaris, is seen and palpated with a bald point, which enters the infundibulum. A 30-degree scope can be used to inspect the infundibulum with a little manipulation. If the bulla does not reach the skull base, the suprabullar recess is visualized and occasionally the anterior ethmoidal artery can also be seen. On retracting the middle turbinate gently, one can see that it turns laterally behind the bulla to attach to the lamina pepracia. This is the ground lamella. As the scope is passed further posteriorly, the third or the horizontal attachment of the middle turbinate is seen. It forms the roof of the middle meatus. The choana, the posterior end of the middle turbinate, ends at the level of the roof of the posterior choana. Accessory ostium may be seen in the region of the anterior fontanelle, that is anterior inferior to the anterior end of the uncinate process, or in the posterior fontanelle, that is above and behind the posterior end of the uncinate process. Accessory ostia are circular and are easily seen, unlike the normal ostia, which can be avoided, tunnel-like and well hidden by the uncinate process. The middle turbinate may show different anatomical variations. Quite commonly, it may be ballooned out due to an air cell enclosed within it. This air cell may be pneumatized from the frontal recess agonized cell or the anterior ethmoids. In such a case, the middle turbinate is called the choana concabullosa. This balloon-like concabullosa may block the osteomeatal unit and the drainage of the anterior group of sinuses. The vertical lamellae of the middle turbinate may also be pneumatized from the superior meatus to form the interlamellar cell of Grunwald. The middle turbinate may have a paradoxical curve bending laterally towards the middle meatus. Occasionally, it may be bifid. The ground lamella of the middle turbinate may not attach to the lamella papracia but may miss the lamella papracia, pass inferiorly to it, and attach to the lateral wall of the maxillary sinus instead. The maxillary sinus in this case is divided into two parts. The posterior part behaves like the posterior ethmoidal cell because it drains behind the ground lamella of the middle turbinate. The lower part of a normally curved middle turbinate may curve far laterally to produce a concavity within it. This concavity is called the turbinate sinus. Here we can see the third pass, ground lamella and the accessory ostium. The uncinate process is removed by a sickle knife or a backbiting forceps to expose the infundibulum. The maxillary ostium can be seen lying in an oblique or horizontal plane behind the intermediate attachment of the uncinate process. This can be widened posteriorly or anterior inferiorly to view the inferior of the sinus with a 30-degree scope. The floor of the orbit and infraorbital nerve can be visualized. This is the window cut in uncinate process with backbiting forceps. Here we can see the normal maxillary ostium and widened maxillary ostium showing interior of the maxillary sinus. The upper border of the attachment of uncinate process is removed along with any cells present in the frontal recess so as to expose the frontal sinus. The bulla is then perforated and is removed systematically in a lateral direction up to the lamella papracia and in a superior direction up to the base of the skull. The posterior wall of the bulla is removed. The retrobulbar and suprabulbar recess, if present, can be studied. The anterior ethmoidal artery may be seen running obliquely across the base of the skull. Occasionally, the anterior ethmoidal artery has a bony mesentery which attaches it to the skull base. Here we can see the uncinate process which has been removed. Bulla is marked in B and suprabulbar recess with a star seen. Dissection of the frontal recess area. Here we can see the interior of the frontal sinus, the base skull after dissection of the frontal recess. We can see the frontal sinus, frontal recess, and AEA. Here we can see the ground lamella, entry point into the posterior ethmoidal cells, the ground lamella. Then we can see the lateral approach to the sphenoid sinus, posterior ethmoidal cells have been removed. Then we can see here the maxillary ridge that is seen here. The ground lamella is then visualized. Its position is confirmed by following the middle turbinate backwards to the point where it turns laterally. The ground lamella is perforated inferior-medially to enter the posterior ethmoidal cells. Care should be taken to preserve the inferior border of the ground lamella so as to maintain the stability of the middle turbinate. The posterior ethmoidal cells are large in size as compared to the anterior ethmoidal cells. They are removed completely to expose the lamina papraceae laterally, the base skull superiorly, and the superior turbinate medially. The posterior most ethmoidal cell has a pyramidal shape, which tapers to a point posteriorly. The posterior ethmoidal artery may be seen running across the base skull. The sphenoid is opened inferior-medially. It is important to note that the bony partition dividing the posterior ethmoids from the sphenoid is not in a coronal plane but in an oblique or almost axial plane. The sphenoid sinus appears globular like the inside of a rounded pot as opposed to the pyramidal shape of the posterior most ethmoidal cell. Another landmark is the maxillary ridge. This ridge is an imaginary line between the medial and inferior wall of the orbit and extends backwards from the upper border of the maxillary ostium. If this ridge is extrapolated backwards, then those cells which open above the level of this ridge are the posterior ethmoid cells. The cell which opens below the level of this ridge is usually the sphenoid sinus. The sphenoid sinus is opened widely to examine its walls. The lateral wall shows a bulge superiorly, which is the optic nerve. Below and slightly behind is the bulge of the internal carotid artery. There is a recess which separates these two structures called the keratico-optic recess. This recess may be very deep if the anterior clinoid process is pneumatized. In a well pneumatized sphenoid, the bulge of the pituitary may be seen posterior superiorly in the midline. The intersphenoid septum may not be in the midline, leading to unequal sphenoid sinuses or a dominance of one sphenoid sinus. Intrasphenoid septae may be present and usually attached to vital structures like optic nerve and carotid artery. Dehiscence of the optic nerve or internal carotid artery may be noticed. The surgeon must take care to whilst removing nasal polyp from within the sphenoid sinus and also whilst removing septae from the sphenoid sinus. Occasionally, an onode cell may grow above the sphenoid sinus, in which case the optic nerve may be seen in its lateral wall. The sphenoid sinus can be approached medial to the inferior middle turbinate. The sphenoid ostium is visualized and the anterior wall of the sphenoid is punched downwards to open the sphenoid sinus. The sphenoid sinus may also be approached by an intermediate route. One can go through the posterior end of the middle turbinate to gain access to the sphenoethmoidal recess and, and the normal sphenoid ostium, which can be then be widened. Here we can see the interior of the sphenoid sinus, onode cells, and the internal carotid artery. Then we can see the intersphenoid septae attached to internal carotid artery, and then medial approach to the sphenoid sinus. Here we can see the dissection of the nasolacrimal apparatus, mucosal flap elevated. Then bone removed to expose the lacrimal apparatus, nasolacrimal duct. The mucosa over the nasolacrimal duct can be removed. Suture lines can be seen separating the lacrimal bone from the uncinate process posteriorly and from the frontonasal process of the maxilla anteriorly. The lacrimal bone is removed to expose the lacrimal sac and dissection can be carried out inferiorly to view the nasolacrimal duct. Thank you. Next we'll be learning about the radiological anatomy.